Hello and welcome. I have the great opportunity of being joined today by Dr. Keith Dawkins. I'm Stephen Bailey. I'd like to talk about the Shockwave IVL therapy and begin to think about where this is going to fit in cardiovascular disease, which really involves everything from the nose to the toes. So Keith, can you tell us a little bit about what the therapy involves and how you see it being used?
Sure, thanks Steve. I've been CMO of Shockwave since May of 2019, and it's an exciting technology and a great group of people to work with. As an interventionist, you know that the calcium burden of your day-to-day work is increasing. And it really doesn't matter whether you treat coronary disease, whether you treat anything below the waist, whether you look at trying to get in an impeller or get in a TAVR device, you come across more and more calcium. And as the age of the population increases, diabetes goes up, renal insufficiency goes up, there's more and more calcification. And we know that the outcomes of patients treated with conventional technology are suboptimal if calcium is around. So the Shockwave technology, IVL, intravascular lithotripsy, leverages what we've known for some time with the treatment of renal stones. And it's been miniaturized and everything's been made much smaller to allow us to deliver that sonic energy into the walls of arteries, be they coronary arteries or arteries in the peripheral vascular system. And the system is incredibly easy. Anybody who can do any form of coronary intervention or peripheral intervention finds it straightforward. There's a box, a generator, there's a connecting cable, and then there are a variety of lengths and diameters of balloon which fit to the connector, run over an 014 wire, and are delivered across the lesion. And then you deliver the energy, and depending on which vascular bed you're in, you may supplement the IVL with a stent in the coronary system, or a drug-coated balloon peripherally, or nothing. And so we're really on a really steep ramp of getting data around the world. I mean, we're now in more than 42 countries. We're obviously waiting for coronary approval in the US, but we have coronary approval in other geographies, particularly in Europe and elsewhere. And so we're gaining data, more and more literature. So we're excited. We're on a very steep learning curve. It's a small company. The numbers in the field are going up, and we're generating as much data as we can, as quickly as we can.
Well, I think as an interventionalist, I'm excited about a tool, as you say, that's easy to use. That's always important. If it's complex, we know that we're not going to use it if it adds a lot to what we do. The fact that we don't have the problems of other atheroblative devices or calcium modifying tools where downstream effects are important. I'm going to have you comment on that.
Yeah.
And the fact that it can be used even post-hoc. We all are concerned about patients who have had stents placed, as an example, either in the coronary or even carotid bed that have been inadequately deployed. So maybe I can have you talk first about what you see occurring in the vessels, and particularly the lack of embolization.
Yeah, so there are some unique features of intravascular lithotripsy. Firstly, it deals with calcium at any level in the vascular bed. So a lot of the serious calcium, as you know, is in the media. And it's the calcium in the media that reduces the compliance of the vessel. And in the case that you just mentioned of a poorly expanded stent, often that's a failure of a non-compliant balloon to adequately prepare the vessel. And as you said, there are obviously other atherectomy devices, both rotational and orbital atherectomy. And when you're shaving off a lesion, you obviously are predominantly treating the intima, and you are concerned about downstream debris. We seem to make very little downstream debris, and we deal with the full thickness of the calcium in the vessel. So if you look at OCT images particularly, you can see the sheets of calcium are fractured because the sonic pressure is generating transiently pressures of 50 atmospheres, and that fractures the calcium but leaves the calcium in situ. So if you, in the coronary space, you typically put in a stent afterwards, and so you can fully expand the stent and you don't ever get that dog bone appearance of the stent or balloons. And so it is transformational from that point of view. Obviously we're still collecting data. But
Well, you've used that phrase a couple of times, collecting data, and to me that would mean that you're doing studies. So I think I would enjoy knowing where you're at with those trials. I think that they are going to be important for us in learning how we use this device.
Yeah. So in the coronary space, we have 4 trials, and they're called Disrupt CAD 1, 2, 3, and 4. So Disrupt CAD 1 was a 60-patient study, really a proof of concept study. Disrupt CAD 2 was 120 patients. And right now we're doing the pivotal trial for FDA approval, which is more than 400 patients in the US, France, Germany, and the UK. And very soon we will have completed that study within a few weeks. And obviously that is the key study. It has very similar inclusion criteria as CAD 1 and CAD 2. And obviously that's the key study for regulatory approval. And we're going to be excited to complete that study, and very optimistic that the data will be presented at TCT later in 2020. And as part of that study, there's an imaging sub-study which will give us additional information for the OCT appearance, all core lab adjudicated, and the study is run as you would expect a US regulatory approval study to be run.
So we know about coronaries.
Yeah.
The calcific burden peripheral vessels is magnitudes greater. And you referenced some of the work that's been done, looking at peripheral vessels. I think that is really an exciting arena, particularly when you're looking at drug-eluting balloons and having facilitation of a vessel that's more likely to benefit. So your comments on that?
Yeah, so we have a number of studies, PAD 1, PAD 2, and a randomized trial, PAD 3, and then an observational registry. The peripheral space, as you know, is in many ways much more difficult than the coronary space. I say, and I would say that as an interventional cardiologist, that it's a bit like the Wild West, because you're dealing with disease from all the way from large bore access, which is obviously a crossover interest for both cardiologists and peripheral guys, to get in an impeller or get in a TAVR device, all the way down to the foot. And as you know, in many of those beds, unlike the coronary area, you're not keen on leaving in stents, either because of the forces, the compressive forces, or because of concern about runoff and stent thrombosis. So if you can treat the calcium over a long segment with IVL, perhaps supplemented by a drug-coated balloon, but no implant, that's beneficial. And we're particularly excited about, we're getting more experience now with our S4 product below the knee, which, as you know, is a real challenge. And interventionists have been anxious about below the knee treatment, obviously because of the size of the vessel, the length of the calcium, and the anxiety about losing a foot or part of the lower limb if it goes wrong.
How about in limb salvage? Are you going to have a specific study looking at opportunities in the limb salvage?
Yeah, I mean there are a lot of and healing. Obviously, there's a lot of areas we have to some extent. We're a small company. We're doing things sequentially. And of course, every cardiologist, every peripheral guy has 10 studies that they would like to do. We do have a robust program of investigator-sponsored research, and so we're supplementing our core studies that we're doing internally with ISRs driven by people like you, obviously, and that provides an opportunity to do arm's length research, off-label research, and it also is driven by enthusiasts in the field. So I think right now we're focusing quite a lot in the lower limb on below the knee and large bore access, because obviously as the number of TAVRs, the impeller goes up, and the slightly suboptimal results with alternate access, if you can go the routine femoral route, it's better.
Absolutely. Great.
Okay.
And enjoyable.
Thank you very much, Steve. Thanks. Thank you.